Abdominal and thoracic trauma. So open wounds to the chest, back, and abdomen. So we're talking about an open wound, meaning there's a break in the skin. We think of this as something that bleeds, but honestly, sometimes with the chest and the abdomen, we may not see a lot of bleeding because a lot of the bleeding could be internal. We'll kind of get more into that as we go here. So open chest wounds, those wounds that are directly over the thorax. So, from the rib cage up, whether that be on the front of the chest or on the back. We usually think of the chest as the front of the body, but when we're talking about a chest wound, this could also easily be on the upper 2/3 of the back. We cover that with an occlusive dressing, or also that's also known as a chest seal. Specifically, chest seals a lot of times will have a one-way valve built into them because, as we know, with an open chest wound, the issue is that air can more easily go in and out of that open wound than it can in and out of the trachea and into the lungs. So if you think back to how our body works to breathe, let me see if my little will work here. So to breathe, we pull this green thing would be our diaphragm. We pull that down, and as you can see, those little blue balloons are inflating, and that's how we breathe. Now, when we have an open chest wound, that's what I was hiding from my finger here. There's actually a cut in the side of this bottle here, and we try to pull this down. We see that those blue lungs either don't inflate at all or just barely inflate now that that wound is wide open. That's what happens when we have a chest wound. We call that a sucking chest wound because as the person breathes, we'll kind of hear air gurgling or bubbling in and out of this hole. And so to correct that, we cover it with a chest seal to get an airtight seal so that as we pull that diaphragm down, the air comes in and out of the trachea and into those lungs. Now, that's pretty much agreed upon in the field. We need to cover it with something. How we cover it kind of varies. Most people will tell you the best thing you can have is an actual chest seal, which again is completely going to seal that wound, but it has that one-way valve. And so the reason for that one-way valve, let me take a step back. If the person has an open chest wound, there's a couple different possible things that could happen. It could just be an opening in the thoracic cavity, in the skin, an external chest wound. And if that's the case, we need to get that thing covered up because just like you saw with the bottle and the lungs, we need to cover it up so air can go down the trachea and into the lungs instead of in and out of that chest wound. It gets a little bit more of a gray area when somebody has multiple wounds, meaning if they have an open chest wound, they could also have not just an open pneumothorax, but a traditional pneumothorax, meaning a hole in the actual lung itself. So imagine a stab wound where the knife goes between two ribs and puts a hole in the lung. Now we have kind of a double problem here. If you think back to a medical or a spontaneously induced pneumothorax where there's only a hole in the lung and there's no opening in the chest, what's the problem? Well, as the person breathes with each breath, air leaks out of that lung and into the thoracic cavity. And as they do that with each breath, more and more and more air builds up into that thoracic cavity, causing the lung to actually collapse. That's why we call it a collapsed lung. Once there's so much pressure built up into the thoracic cavity, air will completely stop even going into that lung with a hole in it because there's under so much pressure that it can't inflate. If it continues, it becomes a tension pneumothorax, meaning that not only is that one lung collapsed, but now the pressure is actually starting to push on the unaffected lung. There's so much air in the thoracic cavity that that lung is actually starting to have trouble inflating. The air can even push on the heart, causing the blood pressure to lower. How do we fix it? Well, as EMTs, we call for ALS. A paramedic comes and they do a needle decompression. What does that mean? That means they give the person an open pneumothorax. They put a hole in their chest between their thoracic cavity and the outside world, and it lets the air out. That air is able to escape, and that extra pressure escapes, and now the lungs can start to inflate again. So if we have somebody with an open chest wound, and they also have a hole in their lung, we have air coming in two ways it's not supposed to. We have air coming in and out of that hole that's we can see. We also have air that's coming down the trachea into the lungs and now escaping into the thoracic cavity. If that air builds up and becomes a tension pneumothorax, we need to let it out. In this case, we don't need to call a paramedic. We already have a hole in the chest. If we've put a classic chest seal on there that has a one-way valve, we don't even have to worry about it. Air can't come into that hole, but it can escape. So if air is leaking out of the lung into that thoracic cavity, it can now escape out of that hole into the real world, out into the world. And so get out of that chest and lower the pressure inside the thoracic cavity, allowing both of the lungs to inflate and allowing the heart to beat without restriction and those kind of things. So that's where this all comes from. That's the ideal of a chest. That's the ideal dressing to use here is a chest seal. However, in the field, people have tried to mimic that by taping your occlusive dressing. Let me take a step back again. An occlusive dressing is just an airtight seal. The simplest occlusive dressing is a piece of saran wrap, a piece of plastic bag, whatever you have that's not going to let air come in and out. Now, if we take that occlusive dressing and we want to turn it into a chest seal, some people will tape down only 3 sides of it and they'll leave one whole side untaped because that way air can get out, but it can't suck in through that plastic. That's the idea. Some people will tape all but one corner. They'll leave one little corner untaped. And that way, again, air can get out, but it can't get in. Some people say, you know what, just tape all 4 sides because if you leave one corner or one side untaped, we have blood, we have sweat, we have, tape that doesn't always stick the best, plastic can get a hole in it, all these problems that can happen. It's too much room for error that air could actually go in the wound and not out of the wound or only one or the, only going in but not out or going in and out, just like we have no dressing on it. So follow your local protocols is what it really boils down to. But just understand the ins and outs that if you do end up doing a 3-sided dressing, if that's allowed in your area, or a dressing with one corner untaped, just make sure those 3 sides or all but that corner are really secure. So there's no way that air is getting into or into that wound, I should say. Now, if you tape all 4 sides and there's no way for air to escape, notice that if you see that dressing start to bubble up with air, or you notice the patient start to decompensate and start to have a lot more trouble breathing, or you see their blood pressure start to drop, you may quickly release that dressing and let any excess buildup of air out of the thoracic cavity. This can only happen if they have a hole in their lung and in their chest. That's how it all kind of works. So I say we're all pretty much in agreement on this, but there is a lot of variation in exactly how to cover an open chest wound. And I'm going to throw one more wrench into the cog here. I was at a medical conference recently, as I said in the last video, and in the field, doctors and working in wilderness medicine, there's disagreement among them whether it needs a dressing at all, whether this needs to be have a dressing at all. So follow your local protocols, whatever your medical director would like you to do. But in general, get that wound covered up. And then if they start to deteriorate, open up that dressing and let that air escape. Okay, so now we get to wounds to the abdomen or the lower back where we're not involving the thoracic cavity. Now we're in a really gray area. I didn't specifically choose the gray background for here, but that was appropriate. Because the 2 of the big standing organizations that would have an opinion on this, that would have stand a lot of ground, would be the Stop the Bleed training and the American Heart Association training. And there's a real butting of heads here where Stop the Bleed says if it's anywhere on the entire torso, it doesn't matter, chest, abdomen, upper back, lower back, cover it with an occlusive dressing. Because our main concern is air leakage into and out of that cavity. American Heart Association says, well, if it's the chest, we'll do an occlusive dressing, but if it's the abdomen, we'll apply direct pressure. Now, when we think about direct pressure, like we talked about in the last video, we're talking about taking gauze and stuffing it inside the wound. Now, if you just blindly go stuffing gauze into somebody's abdomen, my goodness, you could fit a lot of gauze in there. Think about how much space we have for abdominal fat that we build over time. But still, we can really stuff a lot of gauze into somebody's abdomen. If you happen to accidentally be above the diaphragm, you can even accidentally obstruct the lungs from being able to breathe and all kinds of problems. So I'm in the middle of the road here. I say it depends on the situation. It's always my favorite answer. But I'm going to base my decision here on, well, first of all, if you have protocols, follow those, what your medical director wants you to do. But if you don't have protocols specifically addressing this, I'm going to go with, can I see where the bleeding's coming from? If I have an open wound to the abdomen and I can't see any bleeding from that wound, I'm not going to go jamming stuff inside that wound. I have no idea where I'm aiming for, where that gauze is going to end up, how deep it's going, and I'm not going to be able to apply pressure to where the bleeding's coming from if I can't even see where the blood is coming from. So if I don't see much bleeding and it's just an open wound, I'm going to cover it with an occlusive dressing. That's going to hold everything inside and all that kind of stuff. Now, if I have a big open wound on the abdomen, I'm imagining, imagine a dog comes up or a shark takes a bite out of somebody's abdomen or lower back, and you have this big open wound, and you can see where the bleeding's coming from. You can see the blood vessels or the tissues where the blood is leaking from. Now, in that case, I'm going to take my gauze and I'm going to apply direct pressure directly where I think that bleeding's coming from, and I'm going to try to push my pressure up or down or to the side or wherever I think that blood is most likely coming from to try to control the bleeding with direct pressure. So I'm going to leave you with that. There's a lot of gray areas to this for these open wounds to the torso area. So again, just to recap, if there's a hole with air moving in and out of it, get it sealed up. If there's bleeding that you can actively see, apply direct pressure. If it's neither of those or somewhere in between, make your decision or call medical control to see what they advise. Now, another type of open wound we can have to the abdomen is where we have an actual evisceration. And this is where we have actual abdominal organs protruding from the wound. In that case, we're usually not as worried about internal bleeding. We're worried about those organs staying viable and not expiring. So cover any exposed organs with moist, sterile gauze. They're going to be wet. We want to keep them wet. So cover with moist, sterile gauze. And then to keep germs and infection out, cover that with an occlusive dressing. That's going to keep it protected. And also, if the person is getting cold, especially if they have a lot of that abdominal organ exposed, and now we're putting cold, wet gauze on there, they're going to be really prone for hypothermia. So that occlusive dressing is going to also help them maintain their body temperature. So think about covering that wound with moist, sterile gauze and then some type of sterile occlusive dressing to keep that infection out and keep that body heat and that liquid in. And it'll also keep those gauze from drying out too quickly. Now, flail chest. A flail chest is usually not an open wound. It could be. You could have an open chest wound along with a flail chest. But a flail chest just means that part of the chest wall is detached from the thoracic cage. Now, I wish I had a plastic bottle to demonstrate this because it would be really cool, but I haven't gotten that fancy yet. So one of these days I'll have to find the right material to do that. But when somebody has this, typically when we breathe, when we inhale, we make our chest bigger, and that sucks the air into our trachea and into our lungs. To exhale, we relax and we make our chest smaller, and that pushes the air out of our trachea, out of our body. When the part of the chest wall is detached, it's going to go the opposite. So when we try to inhale, we make our chest bigger. It's actually going to suck in that section of rib cage, and it's going to suck in or tent in while the rest of the chest gets bigger. When we exhale, the opposite's going to happen. To exhale, we make our whole chest smaller, and that pushes air out of our trachea. That air is also going to push against that loose part of the thoracic cage. So as the rest of our chest gets smaller, that part's going to push out. And so you're going to see this paradoxical motion where it's moving opposite the rest of the chest wall as they inhale and exhale. What should you do for these people? Help them breathe. They used to put sandbags on there, and then that was too much weight and it was restricting breathing. So then they would put a bulky dressing or a pillow, and they found that was restricting breathing. So now we don't put anything on it. We just take note that it's there, and we do whatever we can to support their ventilations. They definitely need oxygen. And then if you've seen my video on CPAP or oxygen delivery devices in our airway respiration and ventilation training, you know that there's some thought out there that you could use CPAP for flail chest. Follow your protocols on this, but if you are able to use flail chest, you're going to use it at a very low pressure, like 5 centimeters of water. Whereas when somebody has something like pulmonary edema, we use 10 centimeters of water to push that fluid out of the lungs. This is just to kind of help them. This way they only have to exhale, and the inhale will be passive because it's going to be very, very painful to breathe. So as always with CPAP, if you're thinking about trying it, you can put it on them. If they deteriorate and they get worse, take them off of it. Now, I know in my initial EMT training, I always teach flail chest, no CPAP. And one of the biggest reasons is because we don't use CPAP with any chest trauma because of that possibility of a pneumothorax. And that air is going to now fill up that thoracic cavity even faster. So I'm telling you this with extreme caution on using that CPAP for a flail chest. Definitely only do that if it's within your protocols. I would really like to have a someone on scene who is very, very confident in their auscultating breath sounds, because if I can, hear any sign of a pneumothorax and that air leaking out of that lung or not inflating one of the lungs, I'm definitely not going to use CPAP because it's really going to speed up how quickly that pneumothorax becomes a tension pneumothorax. So definitely proceed with caution. Those are there are obviously way more injuries that can happen with the chest. We can have a bruised heart. We can have pericardial tamponade where we have fluid around the heart, all these things. But there's nothing we can do about them. Broken ribs. If it's one broken rib, there's nothing we can do about it. We treat it the same as a flail chest. So these are kind of the big things that you need to know for trauma to keep your patient alive. So that's what we're going to focus on. I'll see you in the next video. Thank you.